Hello, friends. Welcome to essentially, as Scott just told us, speed dating for nurses, where you're going to be introduced to a whole lot of different nursing specialties, and you can kind of see which one you like and which one you definitely don't like in order to just see what might be a good future match. Or if you're just nosy and not even a nurse and you're just like, I want to know about all the different jobs and kind of what they sort of briefly look like. Today is your day. This is going to be a compilation of everyone that is usually on this channel is going to come on and they're going to give us like 5 to 10 minutes of what they are doing, why they like it, like why they're working in the area that they do. And then some like, hey, maybe if you like this type of thing, you should consider working here. And then if you hate these things, definitely don't. So just basically a good overview of the entire nursing profession in an hour and a half, basically is all this is. It's amazing. I know. We're going to start selfishly with me. I'm going to do two because I've done two major things. The other one will be filler if we have like some time scheduled things out. I had to make schedules. It was very hardcore. I'll talk about being a family nurse practitioner for a minute because that's what I did last. And then eventually I'll talk about peds. It's my goal to have timestamps. So if you guys just want to hear about specific specialties, Liz plans on that. She doesn't always follow through though. Okay. And we're going to give her a lot of grace in 2023. It's one of the things we're working on is just, we're making goals and we might not hit them. So there might be timestamps. If they're not there, I'm so sorry. If you are watching live, welcome. Hello. If you're watching in the replay, hello to you too. Thanks for being here. Let's dive right into it. So family nurse practitioner, things that I liked about this job, right? I loved that I could see my humans and get to know them over a long-term basis. It made me so sad in the hospital when I would hang out with them and then they went off into the universe and you were kind of like, bye, I hope I never see you again. But it wasn't in a mean way. It was because you didn't want them to come back to the hospital. I wanted to know like everything about these people. Like, let me follow you and know everything. I wanted to have that. I wanted to have a relationship where they would come to me for like advice and we could just get to know each other long-term over the years. Absolutely loved that. And that is very, very much what primary care was. I don't know if I even said that. I worked as a family nurse practitioner in primary care. So it was like someone's primary care provider. I liked getting to teach them the basics of things. That is very much what primary care is. It is a broad overview. And when you have to get into the nitty-gritty of things, you usually send them elsewhere, right? So you have to be okay with that of knowing a lot about a lot, but you don't necessarily get into the nitty-gritty details. So if you're a super detail oriented, I want to be the person that knows the most about X, Y, and Z. This might not be your thing, but if you're like a jack of all trades, primary care, great. I loved, like I said, educating. I think you have to love teaching people the basics and be okay with teaching the same things over and over and over again, right? This isn't going, a lot of people are going to have, there's like 20 diagnoses that you see in primary care and it rotates. You see a lot more than that, but like that core 20, high blood pressure, high cholesterol, diabetes, upper respiratory infections, pneumonia, weird infections, bites, all of those things you're going to get to see over and over and over again. You're going to have to really like educating people on them again and again and again. And I did. I loved breaking it down for people. I liked having them, going over labs with them and explaining what their labs were. If you need help with that, I do have a video explaining how I describe labs to people. I loved seeing people understand that slowly and then come back to me and being like, hey, I was able to make these changes. So if you love long-term relationships, kind of being repetitive in your education, but also like getting to know people and getting to be really nosy about their life, because you could just legitimately ask and people will tell you an astonishing amount of things. So if you are a lover of a more laid back lifestyle, okay, it's a terrible day if someone comes into your office and needs to be coded. Like that is my nightmare. So if you do not like the high stress situations, if you're like totally cool with being like, you know what, I don't know, but I'm going to go and look things up. And it's totally okay if you don't get to call them back for 2 days because it's not an acute situation. That is my pace and I love it. Then that might also be the pace for you. But if you thrive on adventure and like you wake up and you're like, how quickly can I get a scalpel in my hands? This is not, no, just no, please don't come here. So that is primary care in a nutshell and why I loved being a family nurse practitioner. We're not talking about as many of the downsides today. We do that a lot on this channel. We're trying to start the year off positively. There are many videos that go into the more, all of these jobs have downsides, right? But today we're focusing on the things that made us go into it and love it, right? So that you can maybe look into them too. Also, thank you, Carol Sant, for becoming a channel member. I very much appreciate your channel support so I can be here and do these things and share only positivity with you for this one day before we revert back to where we were and abcamped. Yes. And you need to be coded and you came here. There are always going to be people that walk into primary care and you're like, no, no, friend. They're like, I think I'm having a stroke. I'm like, well, why did you come here? And they're like, well, I know you. I'm like, oh my, oh my, immediately no 911. Let's not even come inside. Let's go sit on the curb. Okay. Let's just go. Now, on the flip side of this, right? Because not everyone is going to be like me and just want things to be like as dull as humanly possible. We have Bree. Bree, we have talked and interviewed Bree before. I will leave her YouTube channel and everyone's socials who's here down below. Bree and I have done an interview before. She's a acute care nurse practitioner, and her days are very different than primary care.
Yeah. If you're coding, come see me. I got you.
Exactly. That's immediately.
If you need help figuring out how to manage your diabetes, I'm probably not for you.
Yeah. Please, yes. Take more insulin. All right. Good luck. Goodbye.
Right.
So Bree, would you like to tell us who you are, what you do, and some reasons why you got into coding people so much?
Yeah. Well, I graduated in 2000, so I spent a lot of time at the bedside, but I've always been drawn to like the acute care kind of roles, like those buzz roles. I started as a trauma ER nurse because trauma life in the ER was the show at that time. Mm-hmm. So I think certain people are drawn to that buzz. They like a little bit of excitement. They just need a little bit more stimulation in life to be engaged. Mm-hmm. That's me. So if you're like that, you'll like those kind of environments. And it kind of segued into ICU, which is where I've been since 2006, both as a nurse and now as an NP. And I think what I love about ICU is that as a nurse, if you're a nurse, it's, to me, of all the jobs I've had, and I've had a lot, it's the place where you get the most amount of autonomy, which as a nurse is hard to get. You know, it can, I think even over the past 22 years, it's gone to very, very like task oriented stuff. It's very document heavy. It's just very like tasky. And in ICU, you still get that one-on-one with people where you get to provide care. It's not always that way, but more so than I think in other fields. So if you like a little bit of autonomy, a little bit more control over your patients, ICU is good for that. It's also good for that little bit of buzz. It's good for like the kind of people who really like to be a part of someone's hour of greatest need. You know, sometimes you do things and you're coding or you're crashing, something's happening, and you have the answer and you provide it. And let me just tell you, the high from that will sustain you for a little while, you know, and then you
for
also,
sure.
Particularly as a bedside nurse, because you're spending so many hours of the day with the family, you develop a very deep relationship in a very short amount of time. And so if the patient has been there for a week and you have to have very tragic kind of conversations with people, you have lasting impact on these people. They are going to go forward remembering what happened with how you treated them. So to me, the amount of impact you have in people's lives is a huge ripple effect. And I'm very rewarded by that. And I think people who are in ICU like that kind of thing. It's also great if the patient is intubated and I don't have to do a review of systems. I really like that. I don't know what to do with people's complaints. I'm like, well, you're not dying. So there's that.
This is the blanket statement of, can you go see your primary care provider about that?
Yeah.
We're like,
that's an outpatient problem. I definitely think you should follow up with that.
Follow up.
Right. Yeah. So that's ICU in a nutshell. I love it.
That's awesome. Is there anything about like what made you decide that you've been in a lot of different jobs, like why either like the type of unit that you're on or like what drew you to that specifically, other than like, yeah, you get like a ton of autonomy. Do you still like, do people get better more, or is there anything like?
I mean, so when I went to nurse practitioner school, I chose Emory because they had a palliative care fellowship. I mean, I was 95% certain I was going to be a palliative care NP. That's what I wanted to do in life. And then like 3/4 of the way through the program, I switched because my teacher and mentor said, you're going to get plenty of palliative talks and engagement with families in the ICU, but you will also get the opportunity to help people and see them improve. And if COVID showed me anything, it is that watching people get better is as rewarding as helping families deal with tragedy. So it's a great yin and yang. It really, really is, you know. Yes. And the ICU where I work currently, it just kind of happened. It was where I was working as a nurse, and it's a mixed setting. But having said that, now I do medical, I do CCU, CVICU, pulmonary stuff, do a lot of things, basically everything but trauma. And I love that because it's always something new, you know, so it's not the same thing over and over again. So you don't feel like you're losing your skill set. So that's kind of how I ended up there.
That's awesome. Do you have like an absolute favorite bit about it where you're like, yes, this is where, you know, this is my favorite part of my job. When this happens in my day, it makes my day?
Yeah. So this is going to, I mean, this probably, there's only a subset of people who will sort of engage with this, but it goes back to my palliative nature. It's weird. Families will say, I don't know how you do this every day. This is horrible. But when I'm having an end of life discussion with a family who comes into a room, there may be 15 of them and they are dramatic. It is the worst day of their life. And they come in sometimes angry with a lot of emotions, and you take them from that place and you provide them with information, prognosis, plan, treatment, and give them some peace about their decision. And by the time you leave, the tears are gone and they're hugging you, and you know that you have changed this family's life for the remainder of their life. You know, I always tell people when they leave the room, I can take care of your person. I'm not worried about this person, you know, and some of this comes down to faith, and I have strong faith, but I can take care of them. I'm worried about you all as a family. I want you all to be able to go forward, you know, still loving each other with no bitterness, and looking back on this feeling like you laid it all out there. You gave all the opportunity to do it. So to me, I leave those kind of discussions feeling uplifted and my cup is filled.
Yeah.
It's not for everybody.
So true.
But
yeah.
That honestly is probably one of the most favorite things that I do. And I also like to teach new NPs. That's a big piece of it too.
That's awesome. And you do a great job at it. Would you like to plug any of the awesome things you do here on the internet?
Well,
that people can go and check out?
Everybody wants a little self-plug every now and then. Well, yeah, I mean, as Liz said, I have a YouTube channel. It is geared towards mentoring upcoming nurses and NPs. I get a lot of reward out of seeing people, you know, to get their dream job and get to that place of happiness, because this profession, while we, and even us personally, talk about all the cons, is truly the best profession in the world. Nursing, there's no other career to me where you can have flexibility, work-life balance. If you don't like this, you can switch to that. If this shift isn't working for your family, you switch to this. You get paid well. You get reward. You get to lay down at night knowing that you have changed someone's life. And what other job has that? So I love talking about our profession. I love helping guide people through it. I do a lot of interview strategy stuff because the difference between the R and the NP interview is astronomical. And I didn't know it until I got into it.
No, yeah.
My husband taught me how to do it. He's a business person. And I was like, why don't they teach us this in nursing school?
I know.
It's crazy. So I do a lot of interview strategy stuff, and I do ICU education stuff. So I have YouTube and TikTok and, you know, basically all the platforms. So if you're looking for that kind of thing, hit me up.
It's the best, honestly. I watch all of her stuff with like, and the acute care stuff. I'm like, I'm really glad I don't need to know that, but that is fascinating, and you're very good at teaching it. So I know it now.
Same when you talk about kids. I'm like, yeah, I don't know. And when my friends call me about kid issues, I'm like, I have no clue. I don't know what the vaccine schedules are. I don't know what that cough is.
Please no.
We all have our niche, and that's a good thing. That's the beauty of nursing.
And like you said, you've changed your job so many times, which I think is cool too, that even if you think it's cool now, like if you're watching this and you're like, I have to pick something forever. No, friend.
No, you don't.
No. You can
just for a little while.
Yeah. Hip and hop and do like all the things.
Right.
Which is sweet.
Right.
Well, perfect. Anything else you want to add about being an acute care nurse practitioner?
Acute care NP. Okay. I will say this for the nurses who are considering going to NP school, because I hear this from students all the time, is that when they do rotations, they're very overwhelmed. And it's like, I'm not smart enough or competent enough to be an ICU NP. And friends, when I was doing my clinicals, I had been working for 16 years, 10 of them in ICU. And I still was like, no, I'll stick to palliative where I don't have to worry if they don't get better kind of thing. Everybody feels that way. So if you like ICU work, trust me, you can learn how to do it and be very, very good at it. I mean, I know the market is kind of tight, but there's always a place where we need NPs in the ICU. So I highly, highly encourage you to just get past that fear of I can't do it and just put in the work. And it's such a rewarding place to work. I love it.
That's
Clearly.
awesome. That's awesome. Well, thank you. I very much appreciate you being on our speed dating show.
Yeah, thank
and
you
for
for
being
having me.
contestant number 1.
Woo woo. Choose me.
I know, pick me. At the very end of this, just as a general announcement, we'll probably do like a quick Q&A, blah, blah, blah. So if you would like to stick around, feel free. But I also know that everyone has lives and, you don't all hang out on the internet like me all afternoon. So maybe we'll see you later. And if not, have a beautiful rest of your afternoon.
Absolutely.
Bye.
Bye.
Okay. Next up, we are going to go to another world that absolutely horrifies me, having babies, which is something that, I mean, less horrifying when I think I went through it, but to have to take care of people who are doing it just like scares me. But before we do that, side note that I just remember to keep an open mind too. Like Bree was talking about kind of discovering palliative care amongst like all of this. And I think as you go through healthcare too, like it's very overwhelming in the beginning to think I have to know exactly what I'm going to do. You will discover things that you had no idea you would ever love. Like people in the chat were talking about how they ended up liking palliative care too. Those discussion, like I agree, like having palliative care discussions, and even in primary care, when we would be on the much more like, hi, I just met you. Like, can we talk about how you plan to die? Which is like awkward until you do it all the time. Like those conversations did become some of your favorite in a way. Like those were so helpful, especially when you could I don't want to say like reap the benefits of it, but kind of that, like when they would come in. And, I've had family members who would come in and be like, I hated you for making me have that conversation, but like this horrible thing did happen. And it actually made it so much easier to know, like, my dad wanted this and I knew exactly what he wanted. You know what I mean? So, and that's like the most rewarding parts a lot of the times. So just keep an open mind and know that you can explore. And like Bree said, there's so many different options. So you can just kind of like follow what feels like the right thing next. You don't have to have all the answers in the beginning. I actually ended up loving doing all kind of reproductive health things when I went into primary care, which if you told me when I went to NP school that like my pap smears would be my favorite appointment, I would have like slapped you with a speculum, but it ended up being one of my favorite things to do. Like when I had that, I was like, yes, like these are and they were younger too. I was like, even better, like give me all the people who are terrified of this and like, let's go. But I would have never known that. So, it's an adventure. So just like kind of see where it's going to go. And now we have Mr. Midwife. Have you ever slapped anybody's with a speculum?
You said that, I spit out my water all over the place. I can just imagine the smear of KY jelly right on. Hi, I'm Mr. Midwife. So I started off in healthcare back about 1992, 93, back when Moses was still a child. And I started off in anesthesia. I worked in a local hospital working as an anesthesia tech. And I was in my position for about a year when I noticed that everybody that rolled through the OR was dead, sick, or dying, with the exception of the few OB patients that we did C-sections on. And I became interested in that. I realized that some of these OB patients, or most of them, are young, relatively healthy people. Everybody gets better and goes home. And so one thing led to another. I moved to a different city and so forth. And here came a job opening for a certified nursing assistant on a labor floor. They're never going to have somebody with a Y chromosome on a labor floor, but hey, stick it out there, see if you get a bite. Well, I sent my application in through the internet, and half an hour later got a phone call back. We'd like to talk to you. So I went down and talked to them immediately, and they offered me the job. And from that point on, I was hooked. I loved OB, taking care of these ladies who were doing everything they could to get pregnant and stay pregnant and then have a baby. And everything we do is positive outcomes. There's a small percentage that don't turn out right, but all in all, everything that we do in labor and delivery, it's a happy day for everybody. And that's what draws me to it. That's what keeps me there. And that's what I love about it.
I forgot to unmute myself. I love that.
Like your lips are moving, but
you're like, well, like, let's just sit here awkwardly. Yeah. And I think labor and delivery is a very unique little gem of a world. What do you love particularly about, so you get to like, do you feel like it's kind of like the one part in the hospital where mostly things are good? You know what I mean? Like, does that kind of have any, obviously it's not all good, but
absolutely.
yeah.
It's the one place in the hospital where 99% of everything that happens there is good. People are happy and they go home. As a nurse and as a midwife, I'm there in your most intimate moment. I'm doing things. We're bringing new life into the world, and one of my favorite things to do is when, especially now, as I cut the cord and hand this baby off to this big burly man with tattoos and piercings here and there, and you look over, he's holding this new little daughter in his arms, and tears are just streaming down his cheeks, and you're like, God, that's what it's all about. And I've seen it so many times. You get these big monstrous men and they're in love with this new little baby, and it really hits you right where you live. On the other hand, you've got two patients. You've got a mom who can talk to you and say, I hurt and I don't feel well, and so on and so forth. And you got another patient who you're trying to interpret the heart rate. You can't really communicate with this baby inside the belly, and you're what's going on in there? What are you feeling? And you're watching the heart rate go up, and you're watching it go down, and you're watching it go sideways, and most of the time everything ends up fine. And then there's the scary points when you're watching things, the heart rate's going boop 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 boop, and then all of a sudden and you go, shit, and you unplug the bed from the wall and you head as fast as you can to the OR, and it's a scary moment. Your heart's in your throat the whole time. You're like, oh God, oh God, oh God. And those are the hard times. Most of the time, we pull things through just fine. Occasionally, it's not. Those are the hard times, though, sometimes. But all in all, 99.9% of the time, it's a beautiful, lovely outcome. And where else would you want to be?
Anywhere. Chad. Anywhere.
No, but once I cut the cord, Liz, it's your problem because you're the
exactly. And I'll take over that problem. I'll be like, thank you, great, let's go.
Yeah, as soon as the cord's cut, it's Liz's problem. Have at it, sister.
Yep. Oh my gosh. I don't know why, but like, oh man, the whole pregnant thing, I'm just like, I just don't have the patience for this. These poor people don't deserve me in their life. And then as soon as I'm like, oh, this is totally fine. I'm fine. Here, give me the baby.
No,
Let's go.
It's a learned skill. Like Bree was saying, you can learn anything. The one thing I can't teach you is compassion. The one thing I can't teach you is how to hold your patient's hand as they need it. Sometimes they just need some reassurance because they're scared to death. It's their first baby. They don't know what's going to happen. Sometimes you just need to bring dad in the picture, and the three of us hold hands and we talk through the situation. And as we're holding hands, I put dad's hand in mom's hand, and now it's them two, and I step back. And I can't teach you that. I can't. I can teach you how to read a fetal monitor. I can teach you how to get the baby out safely. I can teach you all those things. I can't teach you how to be compassionate. So.
And I think compassion is huge in terms of if you're going into that. What do you think, should people like definitely have like, oh, this would be an appealing profession to you maybe if you have this? Because like, I know I couldn't do this labor and delivery thing because I don't have whatever in me. Like if people were like, oh, this is the worst, I'd be like, I mean, you're having a baby. Like, what did you think? Which is the wrong attitude to have. We've talked about it. Like, it's not the appropriate attitude to have in this situation. And I recognize that. So I didn't go into labor and delivery. Love the other end when you come in and you're like, let me introduce you to your cervix. Like, let's talk about it. Let's do all the things. Great. Love it. But for some reason, the labor bit, just like not my jam. What do you think is a good, like, character profile in general of like, if you were to design your ideal labor and delivery midwife avatar?
Wow.
No pressure.
Yeah, for sure. Somebody First of all, like I said, you got to have compassion. You've got to be able to hold their hand and talk them through. Um, it's a very intimate moment. It's a very scary moment sometimes. Um, Women have been having babies for millions of years, and we've survived the fray. But for every patient, this is the first time. And every time, even if they've had 5 pregnancies, this is the first time again. And so you have to have that compassion component. You also have to have the smarts. You've got to be able to read that monitor and interpret what baby can't say.
Mhm.
There's a skill set there. And I tell some of the labor and delivery nurses that I work with now, it's a very elaborate game of chicken. As you're watching that fetal monitor, knowing when to hold your gut, knowing when to flinch, and knowing when to call the game. I did, sometimes even as I got into this really early, I would question some of the doctors. Why are we doing the C-section now? Why don't we wait a little? We got some time. Why don't we wait a little longer? And now I'm in the other side where I'm teaching these new nurses or some nurses the same thing. I want to deliver you early. I want to intervene early. My goal is to deliver a baby that's pink, screaming, and pissed off.
Mhm.
If I pull out this kid and they're limp and gray and doing this, I waited too long. And that's the game of chicken. That's the part where I have to put my brain with what I'm seeing on the monitor, with what I'm seeing with the patient, and just piece it all together and know when we're going to deliver vaginally and when we need to go back for a C-section. So
You got to do all the things. So I'm very impressed by you, and I think you do an amazing job, and all your people are very lucky to have you.
I try.
Yes, you're doing an excellent job. I forgot I was going to do this with Bree. She can type her answer in the comments, and then I'll put it on screen. Chaos meter. Where are we on the chaos? Like on the stress level of chaos? Like I would put primary care at, and this isn't like overall stress because everything has their own stress, but like in primary care, it's very chill. We're like a 2. Okay. The most exciting thing that we really have to deal with is sometimes people walk in and they tell us a totally, different fact. And we're more stressed about their life. You're like, you broke up with your boyfriend? Come sit with me and tell me. And that can be stressful. But like, we're not doing anything crazy. We immediately send them to Bree or Scott, as we'll soon see. Where are you on the chaos? Because I mean, sometimes you have chaos. And when it's chaos, I feel like your chaos is off the charts. And labor seems very unpredictable.
So, like I said, 99% of the time, it's totally humdrum. We've got people on the monitor. Things go fine. She starts feeling pressure. We have a few pushes and boop, out comes a baby. Sometimes we're watching the monitor, like I said, and the baby's heart rate is doing this. We're doing fine. And all of a sudden you look up and baby's went right in the toilet. And that's when your heart comes out your hind end and you're like, oh, shit. And literally on every unit I've worked on, nobody works alone. And so you go racing in there, and right behind you is 9 of your favorite friends. And one of you's flipping this mom over, the other's putting on oxygen, the other's opening the IV up. One of us has got our hand between her legs, trying to figure out what the hell's going on. And then 2 more are unplugging the bed from the wall. Somebody else is at the front at the desk calling the doctor, and we're heading back for a C-section. And this all happens within like 90 seconds. And it's all this, everything's fine until it's not. Anesthesia, we used to describe as 95% boredom and 5% sheer panic. A lot can be said about labor and delivery too. 95% of the time it's humdrum and babies come out. And then 5% of the time you're like, oh my God. And you pull from the bed and run. And now as a midwife, I get to scrub my own C-sections. And so as the nurses are pulling the bed out from the wall and hauling down and heading down the hall, I'm in the back scrubbing, putting on my gloves, putting on my gown, and belly up to the table. The doctor's got the knife and I'm holding retractors, and we're fighting to get this kid out quickly. So it can get ugly quick.
I'm sure that's just great. But
95% boredom, 5% sheer panic.
We don't like the panic here. You might like the panic. A lot of people love the panic. A lot of people do like excitement, though. You know what I mean? Like there's always going to be those people who are like, when there's a code on the floor, like they are like, it's my time to shine, and they're there. And I was like, give me your pager. I'll check on your call lights. Like that was me over in the corner.
Well, that's the other aspect of it. You have to know how to run the code. You don't have to be comfortable and put everything out of your mind. Just start the IV. Put everything out of your mind. Just get the scalpel on. Put everything out of your mind. Just get her onto the OR table
Mm-hmm.
and do your part.
Mm-hmm. High stress or very normal.
For those few minutes.
Good.
Yeah.
We have a roller coaster. Did we ask you, did I already ask you what your absolute favorite part was?
Handing off baby to dads.
Oh yes. Handing off baby to the
Absolutely.
bubbly, the all of a sudden very emotional.
Yep. That's my favorite part.
I hope you get to do that today.
2 times I'm planning. I've got 2 in labor right now. So,
but hopefully they, come on, ladies.
just
that would be me.
Do it before 2 a.m., please. Before 2 a.m.
Come on now. Let's go. Oh, that's exciting. Chad, any final words of wisdom about the world of birthing babies before we go?
I love what I do. I wouldn't trade it for the world. You can keep the peds.
Yep.
All yours. Too many small parts.
Yes.
I love what I do. Any person, man or woman, have proved that is a Y chromosome person, you can do this.
Yes.
I was told for years that there's no way you can understand. And in a lot of aspects, you're absolutely right. I can't understand. But in other parts of it, I've gained the compassion. It took some time, but I gained the compassion and the knowledge to care for women. And I love it. Absolutely love it.
And I think you do a great job. Thank you for coming and sharing with us. Also, everybody out there, if you're scared to see a dude in the realm of like having babies or going for like just like your routine, whatever care, just know that I also was once scared. And then I realized that they don't have necessarily, they don't know what it feels like. And so dudes are so much gentler with everything. I feel like girls are like, this is fine. I know. And guys, the most gentle pelvic exams ever.
I'm afraid to hurt people. So yeah, I try to be as gentle as I can.
Exactly. We have a question for you from Alexa. As an OB practitioner, how often are you on call?
Well, so that's a function of how big your group is. And in my group, there's 3 physicians and me. So we usually take 1 on, 1 off, and then the weekend we do the whole weekend. So I'm on call 1 to 3 times a week, depending on the week. About 6 times a month, maybe.
Yep. And that'll, I think, like you said, depend on where you work.
Yeah.
And how they schedule. Does your office cover, like, do they cross cover other practices? How many people do they pull in?
Well, fortunately, where I'm at, we're the only game in town. You can throw a rock 120 miles in any direction. We're it. It's just us.
Just you.
Yeah, it's just us. So like I said, there's only the 4 of us, and I can't work by myself. I have to be backed by a physician. But if I'm on call, I keep my physician asleep all night long if I can. So that I do all the badges, and if for some reason we have a shit situation, then I call them and they show up. So yeah.
Cool. And I think that's also like a good thing to just realize with the question in general, that different things will have different schedules, right? So he's probably going to go deliver a baby right now. But like primary care, you do have call, but it's much less, and you aren't delivering babies in the middle of the night, right? Like, it's not like you have to bounce and leave. If like Bree would do shift work, right? We didn't really ask her, but I know that that's how that works. So she goes in and she works for a set number of hours and then she goes home. So there's different lifestyle components to each one too, that we'll see. Okay. Everyone go check out Chad, all at Mr. Midwife, all of his stuff. We will leave it all in the description. He's on these panels again, like everyone all the time. We very much appreciate him. He loves what he does. And I love how much he loves what he does. It's very refreshing, with some of the other, like me, I'm pretty just like jaded with the world of healthcare a lot of times, but like you can always tell that like he loves what he does, which is very refreshing. And you're like, oh, okay. Like not everyone, just hates it. So that's excellent. Thanks, Chad. We were just saying you love what you do and you can tell, and we appreciate you for it.
It was the answering service. Sorry.
There we go. See, we're talking about call. All right. Let us now go to someone who has witnessed a baby being born, might happen in their department. And their department is, in my opinion, somehow worse than labor and delivery. We are talking about Nurse Scott's emergency room.
I brought
This
this for
is
you. It's speed dating, and I wanted to make a good first
thank you.
impression. Will you
Thank
accept
you.
this rose?
You win. You win.
Hi, everybody. How are you? I've been watching, of course, and there is no panic in nursing. I don't know what Mr. Midwife is talking about. Maybe that's how they react in other departments, but in the emergency department, if there's something going on, we don't run around with our hair on fire. We're like, okay, this is what I'm here for. I need to do this. I need to do this. You get over there, move that gurney, and we get the job done. So it's a little bit of different mindset.
We're very impressed by you. As much as we all give so much crap to the world of the emergency room, I could never imagine doing what you do. Would you like just to briefly tell us who you are and what you do and why, for some reason, you like it, Scott?
Yeah, my name is Scott. I became a nurse in 1992 and worked in the ER pretty much all the way since then until the last 6 years when I've been disabled. And I have to say, I think that does kind of change my perspective because I'm looking back kind of more nostalgic. I'm not working currently. And so if you catch me on a bad day while I'm working, I might say, oh, this is awful. It's just, I can't put up with these people anymore. But now that I've been away from it a little bit, I look back, it's all kind of, you remember the good, you forget the bad. So I acknowledge that I may be giving you a rosier picture of how it is. But
Fine, we need that here.
I have my own
certainly
channel now, and now I'm in grad school to be a nurse practitioner because I can't do it is pretty physical. It's a physical job in the ER. So I'm looking for something less physical, and hopefully doing advanced practice will do that for me.
Trying to multitask and schedule things, and it's not working well. What do you love the most? Or did you love the most about the ER? What initially drew you to it where you were like, hey, that's where I think I would like to go work?
It was television. I grew up watching Emergency, which was the old show with Johnny and Roy, the paramedics in LA, and they would swoop in and save the day, and MASH. And that wasn't what I always wanted to do, but those I look back now and those were influences. My first major in college was secondary education. I wanted to be a high school teacher. I always knew I didn't want to work in an office. I don't want to be in a cubicle, but I want to do something that, helps people in some kind of more or less direct way. But I got a little disillusioned with teaching, and my best friend was a nursing major, and I switched, and I never looked back. I think I wanted to be like in a crisis as far as why emergency and not some other area. Every nurse is an emergency nurse when the shit hits the fan. I just do it full time. Is the way I look at it, or did do it full time. Mr. Midwife is an emergency nurse when his patient starts to crash and they rush him in to do a section. Bree, obviously, there's a lot of overlap with ICU, but I wanted to be the one that in the room that knew what to do. I didn't want to be the one running around with my hair on fire, but to go, okay, everybody, relax. We're going to do this. You call 911. You open the airway. So that's the role that I wanted in the world.
So you wanted the control to be able to be like, oh no, I know how to fix that. Allow me to fix it.
I wanted to be reliable. A little bit of a hero complex, maybe. Savior complex,
and that's totally fine to admit. Yeah. To be like, I want to know how to fix it all.
The one that saved a life, but I wanted to be part of that team. I wanted to be, I didn't want to be a bystander in life.
For sure. For sure. I think most of us have probably had that moment where we were in like public at some point in something. Like I remember when I was little and like someone collapsed like at church, and I was like, when I grow up, I want to fix that person. I want to be the one that like stands up and is like, I'm not panicked. You're all panicked. That's cute. Allow me. And you just like walk over and you're like doing your thing. And then you're like, well,
that happened actually. And it was a classmate of mine. Her mom was a nurse. And at first the veterinarian came over to the person in church, and Corinne's mom, the nurse, came over and pushed him out of the way. It's like, I'm a people nurse, move.
I'm a people nurse.
I take care of people, move. And I'm like, yeah, that was badass.
That is hardcore. What type of human do you think should enter? Who is your ideal emergency room avatar?
ER nurses are fearless and curious and hardworking and there's so many different skills that go into it. I guess that's nursing in general, but some of the big skills I made notes. Organization, right? You have to be very organized and make notes. Prioritization, you're constantly prioritizing. You've got different patients with different needs. You have to go back and redraw blood on this room. I got a new chest pain patient in there and a baby crying in here. And you're like, which one do I do first?
Mm-hmm.
I put my head in and say, I'll be right with you, and go in. Do you let that one go? Do you do this? Do you go to your charge nurse and say, I'm overwhelmed, I need help? Or can you just do it on your own? Multitasking, you're doing more than one thing at a time. And that's why you keep notes, and it helps you keep track of things. You have to make quick connections with people. You've got a very short time, like Bree said, to establish rapport with a patient and have them trust you. Now, I've always said it's easy to do this job mediocre. You go in, hi, put on the gown, doctor will be there. I need to put an IV in and draw blood. And I've been a patient. I've had nurses like that. And then they come in like, okay, here are your discharge papers. And you're like, I don't even know who you were.
Mm-hmm.
Or you can take the time to say, hi, I'm going to be your nurse. This is what you can expect. I don't have a lot of time, but we're going to do this, this, and this. I'm sorry you're not feeling well. Show a little compassion, show a little empathy. Let them know I'm here for you. If you need anything, ring the bell. I'm going to be busy, but I'm here for you.
Alexa says resilient, not to interrupt you, from the chat.
Yeah. Oh yeah. Because
Mm-hmm.
it's not all rainbows and unicorns. And one of the roles of the nurse, when I went to WGU for my bachelor's, the nurse has 3 roles, one of them being the manager of the healing environment. And that's a big one. You are, all right, this patient goes to x-ray. No, don't take them to x-ray. I need to draw blood first. This one can go over there. Can you pull that one out into the hallway? And I'm going to take this patient from triage. And you're like, can I take this patient? Yes, go now. This is good. Can we do this now and then do that later? And that's part of it.
And so having to be okay with moving parts, which
yeah,
is,
yeah.
If you like stability and no change.
And that is it's the variety of stuff that you see. And it's not like television. It's not all trauma, and unless you work at a knife and gun club, and you see a lot of that trauma and violence and stuff. A lot of it is abdominal pain. A lot of it is kids with fever. A lot of it is diarrhea or a COPD exacerbation or something like that. It's not terribly exciting. Sometimes it is. There's a lot of procedures. Sometimes you can be helping out when the doctor is doing procedures. We do plenty of stuff. We put in Foley catheters, draw blood IVs, nasogastric tubes. Sometimes we'll do like an IJ if you're signed off on it. Some places nurses do suturing. That's pretty rare, but or you at least are there helping out with these other procedures. Cardioversion. I like a good code.
I love a good code.
There's lots to do. There's lots to do, and it's going to be in a 45 minutes. We're going to know up or down. Did we do it or not? And then there's all the touchy-feely, like helping patients and families understand what's going on. There is blood and guts. Some people like the blood and guts. If you watch Dr. Pimple Popper and some of those the toe bro and all those others, you get to see some nasty wounds and some nasty trauma, a lady with a degloved hand, and you get to interact with a lot of different type of people who are smart, people who are not so smart, people who are rich and entitled, people who are poor and entitled, people who are, I won't say crazy, we'll say eccentric. You have manipulative patients, drug-seeking patients, but a lot of people who are just good. They're your neighbors, and they need help right now, and you're the one to help them. And some of them say thank you. Some of them say screw you. A lot of them appreciate what you do, although you'll never know it. I happen to, with my own mental health, had to go and get some help at the local hospital, and I ran into actually a young boy, and he and his mom were there checking in, and it's like, you were the nurse that helped us in the emergency room. Thank you so much. And then I ended up in group therapy with a woman who was struggling with alcoholism, who was like, you were my nurse when I was in the ER. It really, really helped. And I was like, I would have never known if I hadn't run into them trying to, help myself. So goes for nursing in general. A lot of people appreciate what you do, but you'll never hear about it. Just because.
You don't have that follow-up, which is hard, because then you send them out and now you'll have so much follow-up as a family nurse practitioner. You'll be like, whoa.
Bree talked about autonomy too, and none of us want to feel like minions, just making widgets all day long or starting IVs in each room. And there is a good deal amount, although it can seem sometimes like task work, just taking off orders on one room after the other. But there is a lot of autonomy because you get to decide who goes to X-ray first and CT, and then we're going to pull this one out. And Are they ready to go home or not ready to go home? Did we call social work? Okay, as soon as social work gets here, then they can go home. Can they wait in the waiting room, or do they need to be back here? Especially triage. I loved triage because you were the gatekeeper. They came in, you don't know anything, so you're a detective.
Can you tell everyone what triage is, just in case they aren't familiar?
When you go to the emergency room, you walk in and say, hi, I need help. They're like, here, talk to the triage nurse. What's wrong today? I can't breathe. How long has that been going on? Do you have a cough? Do you have a fever? Have you ever had this before? What kind of medical history do you have? Can I get your name? I'll put you in the computer. And then we have a system where we triage or prioritize these patients. If we're open, if there's rooms, everyone just goes right back. But that's very, very rare. So it's like, all right, I got to take the person with the chest pain who might be having a heart attack first. The person who stubbed their toe and needs stitches, if anyone has to wait, you have to wait. And then, of course, in a busy place like in LA, when I worked, people would be coming up. I'd be holding 20 patients or more in the waiting room. And of course, they come up, how long is it going to be? I saw him go in before me, and that's not fair. And you have to kind of do all this managing of that. But you are in control. You do get to decide kind of who goes back. You and your charge nurse decide who goes back. And if is there someone in the waiting room I need to go check on to see if if their condition has worsened? That kind of thing. A lot of autonomy.
Yeah. And a huge blanket, kind of like Bree said, like you're going to see so many things when you work in the ER. It's kind of like med surge. So med surge is when you would get admitted to the hospital. Like both of those, you're just going to see a whole lot. Everything else kind of niches down into their own like little specialties. So do you think if someone has absolutely no idea what they want to do, the ER would be a good place to start? If they're kind of like, I just want to see, and then they can get in there and be like, I never need to see another like snot's not my thing. Don't send me to a respiratory unit. No, thank you.
I think with whatever specialty you're thinking about, do some research beforehand. See if you can arrange to shadow somebody. Don't take a job in a place, to find out if you like it. I think it's better that because then you're going to be 2 weeks in, you're going to hate your life and you're going to like scramble looking for a new job. But yeah, if you research it ahead of time, see if it suits you. It's a very different, and it also depends on the ER. There are big urban trauma centers where it's very busy. You don't ever have an empty room, and you're going to see a lot of acute on chronic conditions. You're going to see injuries and people doing stupid things to each other and to themselves. And then you have kind of the suburban small ERs where it's, the kid who, falls on their elbow playing soccer, or, dad fell off a ladder painting the house, or, kind of suburban kind of stuff. You're not going to have gang violence, out in suburbs. Rural areas, farm injuries, organophosphate poisonings from pesticides, injuries from interactions with animals and things like that. It depends on what they call catchment area, the area that you serve as an ER, the kind of patients, like ethnic background, that kind of thing, and the kinds of things that you're going to see.
Yeah. So it's going to be very different.
Yeah. If you don't want trauma, go out to the suburbs.
And is it true that in the ER, not everything, like, could you just go to the less traumatic side? Like, don't most of them have an area, or do you kind of get thrown wherever? And it's more of like, okay, so as a nurse practitioner, you can kind of pick, I think, in the ER, I want to work on the like kind of like urgent care side, but as a nurse, you kind of have to go wherever. So that's good to know.
It depends on the hospital. Sometimes they'll have fast track, or they'll have urgent care.
That's the word. Yes.
Subacute.
Yes.
Subacute unit, which of course, when it's really busy, becomes an acute unit because you need beds. The ones that I've had, you work where you're assigned that day. Other places, they will say, no, you're one of the urgent care nurses. You're one of the ER nurses. They're kind of a separate thing. And there are freestanding urgent cares, as you know,
yes,
which are kind of similar.
And even emergency rooms. Yeah. Like freestanding. We had all sorts of freestanding emergency rooms where I used to live. I was like, oh, that's hardcore. Yeah. What in Scott's world was a great day where you left work and you were like, I rocked it and I love this. Let's go do that again. What had happened that day?
So many things come to mind. So there's times when we just took time to be nice to someone. I had a kid who had a seizure on his graduation day. And so on my lunch break, I bought him a graduation card, and I had the staff sign it. They're like, oh, Scott, you do have a heart. I'm like, yeah, I kind of do. And that was really, meaningful to them. There's a day when a patient came in they thought had a bad migraine headache, but she was slurring her speech. And I'm like, it could be a stroke. And I'm like, I picked up on symptoms that someone else didn't pick up on. There's so many, because sometimes it's clinical. Sometimes like I got that IV in that baby, or, I really helped. There was one day I had to tell a man his wife died. The doctor was too busy. And I'm like, if you want me to do it, she goes, do you feel comfortable? And I'm like, yeah, I actually do. And that was hard, but very, very fulfilling.
Ugh. So like kind of all over the place. And
yeah.
Which is
You
kind of
never
cool
know.
about the ER, because you have no idea.
You never know what you're gonna get, but you're gonna come home tired, and you're gonna come home like Bree and say, I'm tired, my feet hurt, but I think I helped somebody today. And that's a good way to live a life.
For sure. For sure. Like Bree said, it's different every single day, which is good for people who like need that and want to see it. If you are considering, I think, going back to become like a nurse practitioner or something, I think working in the ER is honestly great. The people in my cohort that by far were the most comfortable with everything were the ER people. They were like, oh, I know about that. I know about that. I know about that. And when the rest of us were like, oh my gosh, like there's so much. There's so much. And these people are like, oh, yesterday I had patients in all of those categories. And you're like, oh, okay, that's super solid. Wonderful.
That's true. Your knowledge, it tends to be very broad, but not necessarily very deep. So you need to know what the presenting symptoms are for like all the diseases and what could possibly go wrong. But I don't know like how to take care of a patient over a week who is recovering from cardiac surgery, or how to take care of, a CF kid or something, is it CF?
But it teaches you sick from not sick, which is a huge skill that you need to learn, especially if you're going into primary care, of who can I treat here? And then who needs to, get moved on.
It's actually not hard. It's a lot like using your motherly instincts or your parental instincts. If you know what normal looks like, because I was that way with kids. I didn't work with kids for the first 5 years of my practice. I'm like, I don't know about these kids. What do I do? When you know what a healthy kid looks like, you know when someone doesn't look like that. You're like, I know what healthy looks like, and you're not that. So red flag goes up. We need to do something. It can be learned,
Yeah,
a lot of
for sure.
is learned. I didn't, graduate high school knowing how to tell a sick person from a non-sick person.
Don't lie. You were born that way.
Experience. Oh, I was. We'll talk about that sometimes, about the crazy weird kid I was, and I was finally tamed.
That would be an excellent episode.
Yeah, if you have a little ADD and you like the variety, and it's not always minute to minute if you work in a slower ER. But it is different every day. It's,
So where are we putting it on the chaos meter?
It can be high. Yes, it can be high, but it's a controlled chaos, as we say. There's a cliche. It's controlled chaos.
They say.
It is, because we don't know what's going to happen next, but I got this. I'm in control. I don't know. This patient's crashing. Okay, I didn't expect that, but that's okay. This is what I do. So we're going to go in there and do that. Hey, can you check on that patient? I go in here, call the doctor. This patient's crashing. So it's control. It's for people who like that kind of chaos. If you like very orderly, like I'm seeing a patient every 15 minutes and then it's, done, and this isn't the place for you.
Yeah.
If you like
that seems very fair.
A lot of moving parts. It makes the shift go by a lot faster.
Oh, I bet.
It really does. I mean, I used to work 12-hour shifts at the busy ER in LA, and they gave us nice big breaks because it's California and we're, it's all rainbows and unicorns here. So we did get breaks, but it was tired. But, you looked at your watch, you're doing this, that, and the other thing. You're like, oh my God, it's dinner time already. I've only got 4 more hours. And then the next thing you know, you're giving a report and going home. So.
Yep. Grassroots RN agrees with you. Says ER all the way. Some of us love the control chaos, love a good adrenaline rush, and it keeps it going quickly. There you go.
Absolutely. Absolutely. But
sometimes
it's not for everybody. And we've already talked about all that. But there's overlaps with other places. And I was not one of the ones, talk about MP school. I have done one job my entire career. And other people are like, yeah, I worked 3 years in peds and then 2 years on med surg. And I did OB for a year, but I didn't like it. I went down to the ER for a while because I was, so they've got a real broad nursing experience. You won't.
I would say you're the anomaly in how you have not done a lot of different things. Because I feel like most Other people are like, yeah, like I did this for a little, I did this, but now you kind of know your thing and you know it really well. So, which is
And,
cool.
when you find what you like, it's like, oh,
Hmm.
do you want to be a
Yeah.
charge? No, I don't want to be a charge. Do you want to do
No, thank
management? Do you
you.
want to go up? Do you want informatics maybe? I'm like,
Hmm.
no, I want to be in a
Hmm.
room with a patient,
I like
taking
this.
care of
Thank
my
you.
patient.
Uh-huh. I found my thing. Now go away.
Yeah.
Kimberly Davis said, I feel like I would be traumatized working in the ER. Like, do you think some of the nurses get PTSD from seeing trauma patients? I would be scarred.
No. And the reason is, and this I know from psychology, is it's how you frame things. It's how you see things. So what's traumatic for one person may not be traumatic for another person because of how they're looking at it and how they experience it. When I walk into a room and there's someone bleeding and it's disgusting, or I see a child. I did CPR on a 3-year-old, okay, and which would be traumatic for most people. I was not thinking, oh my God, this is so sad that this kid fell in the pool and his parents must be devastated and his dad was there and fell asleep and that's how he fell in the pool and he must be so guilty. It's
Oh.
just so tragic. I can't imagine. That's not where I'm thinking. Now, all those things are true. But I'm thinking, okay, I need to get someone on the chest and do CPR. I need somebody on the monitor. Is the doctor in here yet? Good. Do we have a heart rate? All right, stop. I have a job to do, and that's the focus. And if they said for whatever reason, okay, you are off the clock suddenly, just boom, step out here. Now you're just observing. It would be sad. But when you have a job to do, when you're involved in trying to help that person, it's less. There are always cases that get to you emotionally for whatever reason. They remind you of someone in your family, or if a lot of parents are really struck with kids who die in the ER, and
Oh,
people
yeah.
who don't have kids. But I think parents especially are very sensitive when they see a child die because they have their own,
Mhm.
and we just have to be there to support them.
Mhm.
But it's not what there is a difference between. They're like, how can you watch so much pain and suffering? It's like, I don't watch pain and suffering. I try to relieve pain and suffering. That's my
Mhm.
job. I don't,
Mhm.
look at it like, oh, you poor thing, that's so sad. I
Mhm.
think, how can I help?
And I think it depends on the person. You know what I mean? Like, I think that's also how you kind of land in your specialty that you like. Like Grassroots said, I'm glad Scott discusses the ER mind. Some are seriously affected. I've learned to compartmentalize and stay focused on the task at hand because it's my job. And then like kids always hit hard for that person. And I think it just depends on you as a human. Like, can you compartmentalize like that functionally? Like, I'm bad at doing that. So I can't but that's also why I would hate the ER, right? Because I'm really nosy. I want to know what happens next. I don't like chaos and I get too emotionally invested. So I can't see the trauma things. And I know that about myself. So I'm not going to go there. So I think if you're a person who you're like, I would have a really hard time, like just shutting that off and being like, let me do what I can with what's in front of me and not think about it too much, probably not, a great thing to do unless you go and you have a great therapist who can help you get in that mindset. You know what I mean? And like, because I think that could be probably something you would learn. And then just don't have any, like, don't feel ashamed of yourself, if you can't compartmentalize it like that. For a long time, I felt really embarrassed that like codes and like stressful stuff got to me super bad. And now I'm just like, that's just how like, it is what it is. There are other areas that I'm good at that I can do because of that. So it's fine. You know what I mean? So don't torture yourself because you can't fit into a certain little area. But if you can, like Scott said, like that's how you would you can, get into that mindset. And that's how you do get through it. And then
So
also realize that it can change.
I'm surprised it wasn't the first thing I wrote down, but I've also said this, that, all of us say death is a natural part of life. As nurses, we know death is a natural part of life. But if you're going to survive more than 2 weeks in the emergency department, you have to feel that in your soul. You have to believe that because you're going to see people die. And
Mhm.
instead of thinking death is sad, somebody's gone, you have to think this would have happened anyway, but we gave them their best chance of survival.
Mhm.
If they were going to live, it was going to be because of us. If we did nothing, they were certainly going to die. So
And
when
then
someone dies, they die in spite of what we tried to do, and there's nothing we can do about it. It's always someone's time. If it's a child, it's sad, yes,
Mhm.
but this happens every day,
Mhm.
and you can work somewhere where you don't see it and you're not confronted with it. Or like me, I wanted to see life. I want to see the good and the bad, the alcoholics and the domestic violence, and the people coming together when grandma dies, all the good stuff and the bad stuff, the people who courageously fight cancer, I don't want to be sheltered from all of that.
Mhm.
But you might want to for your own mental health. Everyone is
Mhm.
different, but you do definitely have to have a deep belief that death is a natural part of life.
Mm-hmm. And like Bree said too, even like the ER is very much obviously focused on making like avoiding death if possible, right? Because you're going to the emergency room to try to fix it. But there's also that bit of one of the things you can do in healthcare is also just be with people when it does come for that time to like naturally happen and to make it the most positive or at least unharmful experience possible. Because I think we've talked about this before too. Like I never realized until I got working in healthcare that like death is a very natural process and it can be like a good experience. You know, you can have a good death experience where like family is there and it's just like calm and peaceful and not chaos. And
helping people
you're
through
able to
that
provide
process
that.
is deeply
Mhm.
rewarding. When
Mhm.
you're there and you say, you guys, I know you're reluctant to sign the DNR order. You're just like, I got to do something. We got to try to help them. But sometimes when this is inevitable, the most loving thing to do is just be with them. And that's okay. Kind of give them permission to not give up, but change their focus from trying to save the person to trying to just be with them. And I mean, my dad died, and so I've been through that process, and you need to hear that sometimes from someone.
Mm-hmm.
And it's
For
nice
sure.
to be that. It's nice to be that person. And again, most of the time, you got kids with fevers and people with belly aches and diarrhea.
Mhm.
So it's not all this all the time.
Mhm. Yeah, which is a good thing to kind of
It doesn't
remember.
make very good. It doesn't make very good television.
Yes.
It's like
Yeah.
ER, UTI,
Uh-huh.
saving the world one urinary tract infection at a
My
time.
toe has been hurting for 3 weeks. It's 2
Yeah.
p.m. on Wednesday. I thought I'd come check that out.
Yeah.
Let's see what's going on here. Well, thank you. And what would be your overarching, any other, I guess, fact that you would like to share about the ER or things you just wish people knew about the ER?
Be patient. It's hard to wait, but there's a triage process. It's not first come, first served. Please tell all your friends when they go there, don't expect first come, first served. Be patient. We're doing the best we can. The healthcare system is a bit broken, so people come to us when they could go someplace else, and there's a lot of waiting for the
Mhm.
on the patient side of it. But whatever, if you're a patient anywhere, thank your nurse, thank your emergency nurse for the work that they do, and your nurses on the floor, and your nurses at the clinic, and whatever nursing specialty you go into, do your research, look around. Like we talked about before, there are tons of different specialties, ones that I don't even know about, I'm still learning about. And if you want to help people, if in this way, there's a place for you.
Awesome. Well, thanks, Scott. What would you like to plug about your own social media prowess?
I have a social media presence on YouTube. I have a YouTube channel, the Nurse Scott channel. I've got a podcast series out right now that I'm doing called The Emergency Mind, the psychology of emergency patients, families, and staff, where the emergency department and psychology come together because all kinds of crazy, weird thought processes go on in the ER. And I got a merch store if you want to buy a t-shirt or something.
Do it. He turns all the funny stuff where I'm like, that would be a great merch. And then I never do it. Scott does it. So
if
thanks,
you have
Scott.
an idea for a t-shirt, let me know. We'll make it. You buy it, I get $5.
I love it. Well, thank you so much. Scott's always on this channel. He's the
My
best. He's
pleasure.
basically the co-host. We appreciate you.
My
Thanks.
pleasure.
I hope we never have to see you in the ER. Fingers crossed.
Yes.
Nothing personal against you. Just
bring us cookies. Yes.
yes. Bring them cookies. All right. We'll talk to you later.
All
right. Boop. And little mental health plug for people like I said, I think healthcare is in general can just be a lot. And some people are more feeling people. I am a high feeling person in case you can't tell. And if you are fine, I was like just massively, I know we're keeping it positive, so we'll mostly keep it positive. It can be a lot. Just know that healthcare can be a lot. You see a lot of things that are really weird, right? We saw this week with like that football player who had to get CPR on, watch Lemmy be like, let's keep it positive. Let's talk about the football player that needed CPR on the field. But he needed CPR on the field, right? And a lot of the country was really like, oh my gosh, that's a lot. Like we had to watch this happen. That was really brutal, blah, blah, blah. And it kind of puts into perspective that like what we see every day, like codes and like just hearing, even inherently like in primary care, you would have thought going to primary care that, oh, things would be like, fine. Like people are not coding in my office. But you still hear about a lot there's a lot that comes with healthcare, right? Because it's inherently just, it's a lot of people being diagnosed with things, people being sick, things, people not being able to do things to get better, and like just a lot with it. It's very in how it just is just a lot. And there's a lot of trauma that comes with that. And just realizing that, and that it's okay to be really affected by that, even if it's a lot later. You know, it might come back and really surprise you, where you're like, oh, wow, I did not realize that was packed in there and needed to apparently come out. That is okay too. Some of us can compartmentalize and some of us just can't. And, you know, you're all doing a great job and you're all figuring out. I just always feel the need to say that. So here we are for that, if that made any sense at all. And we always appreciate Mr. Midwife. Yes, Scott is the best. Not emotional at all. We appreciate you, Mr. Midwife, for showing the emotion side of things. You know what I mean? Because I think a lot of the times we think that we have to like be all, you know, I'm all bottled up and I'm fine and everything's good. And showing that we are humans and deal with stuff is very helpful. And we very much appreciate how authentic you are, and you're the best. And I'm glad you're here. Next, going back to the world of labor and delivery, which I feel like on here, I'm like, I hate all your specialties except for mine, but that's how I feel on the inside. So I guess we're just being honest today. We have Chelsey, who also, for some reason, she loves the labor and delivery things.
I feel personally attacked that you don't love labor and delivery.
Oh, I just don't.
Just kidding. It is very much either you love it or you hate it. Specialty. So,
what do you love about it? Why do you do it?
I became a labor and delivery nurse. Well, I was in nursing school whenever I had my first baby, and kind of my experience made me be like, man, I want to be a labor and delivery nurse. And to be honest, it's like the experience that I had, I thought I want to become a labor and delivery nurse so that I can be a better nurse than what I had. Looking back as a labor and delivery nurse, I feel like it was not as bad as I was like making it out to be, for sure.
Which just shows you how vulnerable you are. You know what I mean? Like as a patient, that like that is a heightened moment.
Yeah, I was a difficult patient for sure. Okay. So I feel sorry for that nurse who took care of me. It was a combination. It was both of us. I was a difficult patient, and she was like a burnt out, on the edge of retiring nurse. And so it just wasn't a great combination.
But see, that's the thing. You're allowed to be difficult. And that's why I don't work in it, because I would just be like 0 tolerance. And that's not fair. Because especially when you're having a baby, like you're allowed to be difficult.
Right. Yeah. And here I am. And I love it. So it worked out. It's very much labor and delivery. I know not on this channel, but in the nursing community in general, I feel like it's not a fair representation, or we're thought of the princesses in the hospital and stuff like that. So I really want to try to put some myths to rest here, because labor and delivery is like not for the faint of heart. It is very hard. We do almost every other specialty of nursing. Like we do everything. I have only ever worked in rural hospitals. Like I have never worked at a hospital that has a NICU, for example. So as a labor and delivery nurse, I triage patients like an ER nurse would. I can circulate C-sections like an OR nurse. Sometimes I have scrubbed in like a scrub tech. I take care of patients who have medical problems like diabetes and liver problems, kidney problems, etc. I take care of post-surgical patients. I take care of patients who are on drips like they would be in the ICU, like insulin drips, mag drips, things like that. Pitocin, which isn't a drip that anybody else would be on, but it is a high-risk medication that that needs a lot of attention, like other drips would in the ICU. And like we do all of this with one patient nestled inside of another patient. So it is not for the faint of heart. It is like the critical thinking skills that a labor and delivery nurse needs are like some of the highest, I
Astonishing.
believe, in the
Yeah.
hospital, because again, like I said, I have only ever worked in smaller hospitals. And so I do not have physicians or providers at all in my unit at all times. Like they are there if I ask them to be there, which means that it's on me to know if they need to be there or not. Like I am quite literally the eyes and ears of the physician or provider. I'm sorry, provider. I said as somebody who is in midwifery school, I need to get better at that. But I've never worked with a midwife, so like physicians.
It makes it hard. Yeah.
And so, or like if a bad, I probably shouldn't say bad baby, but that's what we call them. If a baby comes out and is not transitioning well to extrauterine life, I am the NICU. Like I am the person, usually not a physician. Like it is literally me. I am the one resuscitating this baby. So you have to have all of these skills. Like it's not just like the specialty of labor and delivery. It's not just watching the monitors. It is so much more than that. Plus I also have to watch these fetal monitors. So
yeah, because as soon as you start hosting someone else inside your body, no one else will touch you. At least that was my experience. Like I don't primary care. I'm like, well, there's a different people now that you go see. Congratulations. Goodbye. Come back when you're just yourself again.
A fight with like the ER for them to keep a pregnant patient. Yep. And I know that Chad was talking about how it's normally good outcomes in labor and delivery, and it usually is. And you guys also talked about how our patients are well. It's one of the places in the hospital where our patients usually aren't sick, not like in an infectious sort of way. Yeah, we have lots of patients who are sick with preeclampsia or with cholestasis or something like that, but not like in an infectious sort of way. And we try to like protect that at all costs. Like I don't want a sick person in my well unit with all of my pregnant moms and brand new babies. And so sometimes it can be like, with the ER, like, hey, I know that you are really uncomfortable with pregnant patients, but I don't want that person who has the flu up here actually with me. I'll come to you. I don't want them up here.
Yep.
So, yeah.
And I think that's a very good point. And I'm glad you set the record straight, because there are definitely, yes, people are like, oh, you're just going to go labor and delivery and watch monitors on the wall.
Or just like cuddle the babies afterwards. It's
you and the NICU nurses, it's all you really do.
It's all we do.
People have babies and you sit there and hold them, snuggle them. It's very,
So I think that this is the best specialty ever. Obviously, I would. I was very offended the other day whenever it ranked so low on your list. But I think that everybody should give labor. Like if you feel like you want to do a lot of different things, labor and delivery could be for you, because we have skill sets from every other specialty. Even like palliative care, bereavement, we do a lot of that. And so really, I mean, we do it all, especially again, whenever you get to bigger hospitals and there's labor and delivery nurses, and then there's postpartum nurses, and then there's NICU nurses, that gets a little bit more. I've never done that. I've always had to do it all. And so, which I love. I feel like that makes a very well-rounded nurse. So that's whatever I'm talking about whenever I say I have all of these skills that I have to hone. It's in the little bit smaller setting. A postpartum nurse isn't going to necessarily scrub or circulate the OR or resuscitate the newborn or something like that. But for me, that's what I do. And I love
that. That's a ton. Especially when you start to think about too, that like if your unit does, like I've always worked at bigger hospitals. So people tended to, you had to get trained on all of them, but then you kind of went to like people who were high risk. OB was in its bubble. And then you had actual labor and delivery, which is where they were having babies. And then you would go to postpartum, and people separated, and you definitely did like kind of niche down into your thing. But if you have to do all of it, like that's a lot. That's a lot to have to know how to do, because you're, like you said, you're an ICU nurse, and then all of a sudden you're like a NICU / early primary care / I'll also teach you how to like use your body to feed another human while everything is falling out of you, and make sure you're fine. It's fine. Everything's fine. Here we go. So you're superhuman. I'm very impressed. I don't want to do it. What is your best day where you leave? You're like, yeah, that was good.
I have lots of different kinds of best days. Like I might have a best day where I have a patient who the probability of them achieving their desired outcome, which may be a vaginal birth, is really low, but we work our voodoo magic and we get them that vaginal delivery and everybody is happy and healthy. That like you leave those shifts and you're like, man, that was a very long, hard shift, but we did it. We got her the best outcome that she wanted. Also, I know Chad has talked about this before as well. It's like weird to say my best day or my favorite day, but if I have a family who has suffered a loss and like getting to be there for them in that and support them and give them resources and help them through that really tough time, that can be very rewarding as well. There's lots of different, because we do like, there's so many different aspects. Like if I'm on postpartum, then maybe my like going home that day as a great day would be teaching a mom who is a recovering addict and having to take Subutex, teaching her how to comfort her baby who is withdrawing from the Subutex and letting her know that like, I know that this is hard to watch your baby go through this, but this is what's best for both of you. And this is just part of the process. We all expect it. Nobody thinks that you are a bad mom because your baby is withdrawing from this medication. This medication is saving you, and it probably saved your baby's life, and teaching them how to cope with that. That's also a really great day. So there's lots of different kinds.
I love that. And I think one of the things that highlighting too is that like a lot of times it's in the really difficult or non-traditional, like difficult, what would be perceived as like, these are really hard situations. And that seems to be what everyone's like, this made me feel the most impactful moments which is just interesting because I think that's not what we think going into it. You probably went in thinking like, I'm going to deliver babies and I'm going to be like, oh my gosh, like, look at me. This is my best day ever. When in reality, you feel the most, like you're doing the most in those situations that are like, oh, like, I hope I never have to see that type of thing.
Yeah. And childbirth is interesting because, like it just happens. Like it's going to happen if I'm there or not, and so
good point.
the amount of meaningful, I mean, I can't have meaningful impact. I can help a mom through a really tough labor. I can have impact there, but it's when things aren't quite right that the real potential for doing good and having a good impact is there. So,
well, your patients are lucky to have you too. I think you would you're an awesome labor and delivery nurse, and
thank you.
Your patients are very lucky that they get to have you, and all your future people who are, when you're a midwife, you're going to be like, yes, you and Chad are going to take over the world. It's going to do the best. I love it. Who would be your idea? Like, who would you think would be a good person if you were going into labor and delivery? What characteristics might one have that would be helpful? Like more patients than I have.
Yeah, you need to have patience. Now, I'm not a person who has much patience. And so I think that there's compartmentalization that can happen. Like whenever I'm at work and I'm taking care of patients, my impatience gets compartmentalized away. And I am Nurse Chelsey, who is going to be like the most patient and compassionate person with you. So if somebody isn't patient in like other areas of their life, like with my children, I don't necessarily think that that's saying that you can't do this.
Yes.
I do think that you need to be able to have compassion, and in labor and delivery, especially, I feel like it will behoove you if you are like a quick learner and you have really good critical thinking skills. That is something like I'm a nurse educator as well. So like I am a labor and delivery nurse, all of the things that I talked about. I'm also our unit educator. So I help to teach our nurses on our unit and like our graduate nurses who are coming in. And one thing that's like always a struggle is I cannot teach you how to critically think. Like that's just not something that, like, it's really hard to teach somebody how to think critically, especially like, I don't know, like at this phase, you know, like I feel like that's something that's easier taught a little bit before the phase whenever they're coming to me. So if you are good at critical thinking and you can think quick on your feet and are a quick learner, those are all things that will behoove you in this specialty.
So just be willing to, look at everything, learn a lot of new things. And oh, well, thank you. I appreciate you. You're doing awesome things. Do you have any social media or things that you would like to flaunt?
No, I don't.
Not yet. It's still a pregnant idea. That's a German phrase.
It is. It's
from my
it
German
is pregnant.
It's
And like we said last time, who knows how long I will have to gestate this?
Yeah. Sometimes it takes
ready.
a very long time. It might be like an elephant. It's like 2 years.
It could be. School's getting ready to start back. And so who knows? Because I'm just about to be dead again.
Yep. Well, the longer you're pregnant, just know we expect it to be like running when it's born. So fully functioning.
I will not launch a channel until I have 50 videos ready to go.
Exactly. Full force. Be like, here you go. Worth the wait. Here we are. Chaos meter. Forgot the chaos meter.
I feel like Chad did pretty good with this. It's either 2 or it's off the charts. And I feel like when it's off the charts, it's not off the charts with one patient. No, we're talking about the whole unit. The whole unit is either nice and everything is going fine, or every patient is having an emergency at the same time. That's just
it's some kind of a hormonal chemical reaction. I'm convinced that it's like, oh, we're doing this. Okay, we're doing this. Let's go.
Yeah.
No, thank you. Well, I'm very glad that you like to do it and that you love it. And I think you're another very positive voice of all of the things, even when I'm being very grumpy, that it's obvious that you love what you do. And I very much appreciate that. And thanks for telling us. Anything else you want to add about labor and delivery that you think the general public should know?
No, just do it. We do not just rock babies. Also, this is something that like I see a lot as an educator, and it's frustrating. Don't come to labor and delivery if you are thinking that you need a slower pace from something like the ICU or something like that. Those nurses like don't last very long. This is not the environment this isn't the place that you come to retire. This is like, you need to be on your game. And this, like, you can't ever just like, turn it off, like you always have to be like ready and looking for the emergency that's going to try to come up and like steal your joy. So,
and like, the more I think about it, because that is definitely a stereotype, right? When we had people that would go to labor and delivery, like, oh, they're going to go sit on their princess perch and watch strips. That's like what people say, right? And the more you think about it, it just doesn't make sense, because like your patient is hiding another patient inside of them, but you can't really see or communicate with them, and anything can happen. So I'm glad you stood up for yourself, because the more I think about it, I'm like, that doesn't make sense. Go to PACU if you would like to do that.
This is the hill that I die on.
Yes.
We are legitimate nurses. We do all of the things. We do all of the specialties. We're all of them wrapped up in one with another patient inside.
Yep. And then as soon as you send anyone to us that's pregnant, we're like, oh, labor and delivery is going to have to do that, because I'm not touching that. After we've already disgraced you. So
I did once ask a nurse. We were like crazy busy, and this was probably not very nice of me to snap at. I don't remember if it was a med surg nurse or if it was an ER nurse, but they were like, I need you to come and doppel this like 18-weeker who was on another floor or something like this. And we were so busy, and I was like, do you have Dopplers? And they're like, yeah. I was like you do for like pedal pulses? And they're like, yeah. I was like, that'll work. You can do it. Why don't you go try? Just try, confirm with a radial pulse on mom that you're not getting mom, and you call me back. And if you have problems, let me know. I'll come. But you try it first.
You try it, and you can do it, nurses, if you're out there. We used to steal our pedal Doppler all the time and check each other when all of us were very early pregnant, and then need to call our midwives as soon as their office opened. And they're like, "Why are you panicking?" You're like, "Okay, don't judge me. I might have been fooling around with a Doppler, and now I'm panicked, and I'm gonna need to stop by before I go home." And they're like, "I've told you 8 million times not to do that." And you're like, "I know." I'm so
It
sorry,
happens.
but now here
It
we
happens.
are. Here we're coming.
Yep.
We have questions. Alexa said, because you work in a small hospital, Chelsey, have you ever been on call because it's in such a specialized area, or does it work more like shift work?
Both. So we do shift work, and then we have mandatory call that we have to take. And so, like, especially during the week, on nights, usually that's whenever it is. You take, and it's going to be different at every facility. At our hospital that I'm at now, we do 8-hour call shifts, and so you just sign up when the schedule comes out for your call shifts, because nobody else in the hospital can help us, because they don't.
No,
they don't
no, we do not do that. No, thank you. JB said, Chelsey, I'd like to be a women's health nurse practitioner. What experience would be good to have as a nurse, labor and delivery, postpartum, etc.?
As a women's health nurse practitioner, I feel like labor and delivery would be helpful, or working a gyne floor. Like if your hospital has a surgical gyne floor, that might be good as well. Women's health nurse practitioners are going to be a lot more outpatient focused. Like, not all of the things that you're going to see, like working as a labor and delivery nurse, it'll only help you so much in women's health nurse practitioner, because women's health nurse practitioners aren't going to be doing labor and delivery. They don't have those kinds of privileges. They might see patients throughout their pregnancy, and so that might be helpful. But if you're going to be a women's health nurse practitioner, it might be more beneficial to like take a job in a clinic, at a women's health clinic, or on a, like I said, a gynae floor or something like that.
I'd say, yeah, anything that's the biggest thing that's going to be the most important here is just getting used to talking to people, almost, and like learning how to just assess people and get people, like, because what you are going to end up doing is very, very specialized. And until you really do it, you're not going to, at least that would be my thought, because you're going to be doing, like Mr. Midwife said, pap smears, breast exams, talking about menopause. So yeah, if you can get a job on like OB-GYN or like gyne-onc, which is like gynecology, oncology, that's sort of the population, or then just like the ER would probably be fine, med surge, even like the ICU, anything where you're just going to learn how to talk to people and just kind of, because that's sometimes one of the biggest things, is just getting really comfortable with patients and learning sick from not sick, and you'll get that. Let me see. I think there was one more. Oh, Julia said, is it hard to get a job in labor and delivery? To me, it seems very popular. I hear a lot of people want to go into that.
Like I said before, it's like either you love it or you hate it. Like with nursing students, I feel like they are either like, that's what I want to do. And for me, I was so sure that this was what I wanted to do, that I was not going to settle for any other job. I was not going to settle for a job on a med surg floor or something like that, which ended up meaning that I graduated in May and I didn't get a job until November, because I was not going to take a different job. I knew that this was what I wanted to do. And so it can be hard, especially like depending on the area. It used to be a lot more common for labor and delivery units to not want to take graduate nurses, because it's a lot of work to train them. But it's becoming a lot more popular to have graduate nurse residencies, which is like what my hospital does. And so we will take graduate nurses. But labor and delivery is definitely one of those specialties that not a ton of people leave to do other specialties. Like usually if you do it and that's what you love, that's where you want to stay, because there's not really another specialty that you're going to get the same types of things and the same flow and stuff like that. So in that aspect, a lot of times units will fill up and then there won't be any openings for a long time until somebody retires or like has kids and doesn't want to come back after having kids or something like that. There's just not a lot of turnover in our specialty. And so that can make it hard to get an in. And it's not so much that like we don't want to hire new people. There's not a lot of positions because we love it and we don't want to leave.
which is a good sign. A great sign for anyone looking for a job is how long are people there? Oh, they come here and they live here until they retire. That's where you want to be. That sounds perfect. Well, awesome. Thanks, Chelsey. I appreciate you.
Yeah.
Thanks for giving us all of your knowledge. I think I'll talk about peds really quick, guys. And then we'll do like a general Q&A. We can answer like 1 or 2 questions. And then I have to go. It's my husband's birthday and we've got shenanigans to go do.
Happy birthday, Mr. Nurse Liz.
Some kind of a party. And my children made me a crown for it. So I said, what's this? And they're like, it's for Dad's birthday. And I was like, and I get a crown. Well done.
And did he get a crown?
He did, and his was colored. Like they colored on it. So mine was not decorated. They were like, yours is not decorated.
Yours is plain.
Yeah, they're like, as it is not your birthday. I was like, that's fair. But there we are. All right. Well, thank you. We appreciate you.
Thank you. I have to go pick up my kids. So.
Sounds good.
Bye.
Good luck. Bye. All right, friends. Real quick. Peds is obviously the best specialty. Okay. Except for 99% of the population who hate it. Like I hate everything else. Okay. Kids, you either love them, you either love peds or you're like never. And since I love peds, that's where we are. Kids, they're great. If you like resilient little people, I knew I always wanted to work with children. I don't know why. They make me laugh. They like can handle anything. My pediatric patients would literally have 3 chest tubes, a fresh sternotomy from having open heart surgery. They're like, IV, like central lines hanging out of them. And you're like running down the hallway after them, trying not to drop like everything that we have. Right. And they were just fine. Coming from the adult world where you had to like literally someone would have like, some minor laparoscopic, not minor, but like a laparoscopic procedure. And they're like, I can never move again. And these kids are like, let's go run a marathon. Very resilient. They're funny. The things that they say will just like catch you off guard. They're much smaller. So the things that come out of them, like poop, is much smaller. It's a really cool opportunity to empower patients. If you like educating parents, this is awesome, right? Because you have these terrified people who are in charge of this smaller human and their life just probably got turned upside down. And you can teach them how to take control of a situation and be like, here's what you do, right? So that you can feel like you can help your kid and you see them walk into the hospital being so scared and like, my world is falling apart. And by the end, you're sending home a parent who can change a trach while their kid is like, having a fit about something. And then their NG tube falls out and the parent can put the NG tube back in. And they're like, oh yeah, this is all like just fine. And you know that you taught them and you did that. You helped them learn all of those things. And it's just great. They make you cards. They come back and see you and they're the best. I will say in peds, try not to work in a specialty that is super sad, right? I worked in a surgical specialty. So they came to us, 99% of them got better and we sent them on their way and they could come back and see us. So that is my caveat to the whole pediatric situation is that you work somewhere where they do get better. Peds can be really, really hard if it's on more of a chronic side of things. I don't know how people do pediatric oncology. But in general, peds, as long as you're fine with the parents, because parents are usually the part where everyone's like, nope, nope. Not all, most parents are just worried, I have found. And if I approached it with, I'm just going to verbal diarrhea my entire experience with you, I'm going to walk in the room and everything I do as I'm doing it, I'm going to explain it before, it worked a lot better. And then the kids are just funny. And like, it's so refreshing to just have their attitude. They're funny. They're very, very brutally honest. And they're just cute. If you like working with kids, you just like working with kids. I'm like, this is just the best. And I love you. And you're so rude and so small. And I just love it. They're so ornery. They like can climb out of their cribs and like hang off and hit the code button or the staff assist button just to get your attention. I would have kids that knew they had pacemakers. They knew it. They were in their bellies because in kids, pacemakers go in bellies because you don't have enough room in your chest. And they would have iPad cases that had magnets in them, and they would hold it over it to get your attention. So you would come running into the room because it would stop their heart because it made their pacemaker stop. Like they're like 3 and they knew how to do that, those little suckers. But like it also somehow made you like them more. You're like, you're evil, you little demon, but I love you. I'm like, I'm going to come back and do this again tomorrow. They're just weird like that. You know, they'd take their trach out if they were vent dependent, and they would just stare at you and to make you come in the room when they were all gowned up. Like you had to like space suit up to go in, and they knew. So they were like, I'm just going to take this out. I don't know why I love it, but I love it. And if that sounds awful, but also appealing to you all at the same time, you too might love peds. So welcome, come over. And toddlers are very strong. Yes, Alexa, toddlers are so strong when they don't want to do something, and it's super scary. Yeah. Like toddlers and 90-year-old women, their strength is unmatched. I cannot tell you how many people it holds down. Like I worked on a post-cardiac surgery floor. And so you had to like change chest tube dressings and like they had also everything hooked up to them. And you have to clean that stuff because then they poop and barf all over themselves. You have to change all the stuff, all the things. And the amount of people, or to get an IV in a child, like, or get a blood pressure, God forbid, you want to know what their blood pressure is, it's going to take so many people. And then you're like, well, you're either having a stroke or you're screaming, and you're definitely screaming. So hopefully you're not having a stroke. So if all of that, with that shining recommendation, somehow there's going to be some of you out there who are like, that sounds awful and I want to do it. Welcome. You're probably a peds nurse. Come join us. They're very strong, but they're so stinking cute. And then when they make you drawings, you're just like, who's that? And you're like, it's you. It's for you. And you're like, oh, fine. Everything's going to be totally fine. You drew me that. It's great. Alexa also says family medicine is a place you can learn about women's health. Absolutely. You learn a whole bunch of that in primary care. I love that. And yes, that wraps up, some of the specialties. Alexa said we should do a part 2 with other specialties. If you agree, let me know in the comments. And if enough people, I don't know, an arbitrary number I make up, seem to be interested in that, then yes, because we have all sorts of other people that can come in who couldn't make it today. So maybe we can find a time. We have a nurse lawyer. We have our whole other, half of the population who, when I give them 4 hours notice, couldn't make it. How dare they? But Chad, Scott, we'll bring you back for just a moment. Does anyone have any? We can take like 2 general questions, and then I have to go make peanut butter and jelly sandwiches like crazy. But thanks for being here.
That was
You're
fun.
both great.
Always.
Yeah.
I'm down for a part 2. I won't chime in
Another
this
speed
time.
dating?
I've spoken my piece.
Oh my gosh. No. But yeah, so if you guys like it, we can definitely do part 2.
Yeah, definitely. I like Chelsea's comments. I learned a lot. I never thought about OB as calling on skills from all the other specialties, but I think she's right.
I know.
And she said stuff that I didn't get to say. We do everything. We triage, we monitor, we scrub surgery, we circulate surgery, we do NICU, we resuscitate dead babies, all sorts of stuff. So yeah.
Yeah, you do a lot. And we still like to make fun of you. I did. I was giving the PACU crap earlier. I was just giving the PACU crap. The PACU is another one that just scares me. Why do you want to wake people up out of anesthesia? That sounds like that sounds stressful. Yeah, that would be PACU nurse here. Trust me, it's not slow down there either. I do not think it's slow. We recover critical care patients, critical labor and delivery patients, interventional radiology, endoscopy, you name it, we recover them. The way I see PACU is you're taking someone who is like, they just cut you open and they are unconscious, and then they send you out and you get to find what went wrong, which is my personal hell. So in case you're figuring it out, many things sound awful except for the 2 that I picked. But I joke that the PACU is where you go because you're just, letting people wake up slowly. No, the PACU sounds terrible. I don't know how you do what you do. That would be way too much suspense for me. It's like, are you going to wake up and be fine? Or are you going to wake up and like things did not? No, no, too much. I would love to find people in, if you work in like prison care, if you work in corrections, do let me know, because I'm looking into some other story and I need someone with that insight. Oh, perfect. Welcome. Excellent.
I did corrections for 3 years.
Oh, perfect. Well, there we go. I have a story that I need to discuss with you. We can chat about case management.
Call me later.
If anyone knows a flight nurse, you're famous, and let them know, because I am so impressed by flight nurses. The problem with this is very much an unpaid setup here. So these lovely gentlemen donate their time on the interwebs, but like not everyone's down for that. So I would love to interview all of these other types of humans, but it's not the best deal if we're being honest. I'm like, hi, would you like to come ramble with me on the internet for 3 hours? And they're like, great. How much are you paying me? I'm like, well, sometimes we're funny. And they're like, and they're just like, well, that's
You can get some extra initials after your name.
Yeah, I'm like, you
That's
can
right.
become part of the fanny pack, and you
Yeah.
can put it on your resume. So
I would love to learn more about some other specialties I don't know enough about, like OB, and about the ongoing, battle between med-surg nurses and ER nurses. And I'd like to hear about what they do and what their expertise is and how they see what they do. Because I think we need to understand each other better.
Absolutely.
And people watching, there are so many more.
Oh yeah, that was my point.
Even touched on today, yeah.
That there's like so many more, and I would love to be able to bring all of them on, but I only have so many friends, guys. I only have so many friends, but the friends I do have are wonderful, and I appreciate you, and I'm so glad you're here. But yeah, like home health, very different. We'll have to talk about corrections nursing, Chad. We might rope you into that because that's a very interesting thing. And yeah, the flight nurses, they just know how to do everything, and they get to wear a cool spacesuit. And
I swear to God, when they come in the hospital and walk down the hall, mysteriously heroic music just starts.
I was just going to say, they have like the little like walk, and everyone's like,
it's in slow motion, like those
Mm-hmm.
astronauts walking out to the rocket. It's just,
it is.
Yep.
That's literally how I imagine it.
That's what I wanted to be when I was in nursing school. It didn't work out that way, but I did do some ride-alongs, and I can tell you this about it. It's stop or go. They're either sitting there waiting for a call because nothing's going on, or it's like beep, 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 beep. 3, we're out, we're flying, and go. But it is really cool. It's like being an ICU nurse or an ER nurse, except you get to fly in a freaking helicopter. It's very cool. I have a fascination with
10,000 feet. Absolutely.
Yeah.
I don't know. I don't know how they do that. I can't even fathom. Can't even begin to imagine, but it sounds amazing. Okay. Someone was, a nice person said they had a good perspective from a different one. I'm an RN and a urodynamicist. I'd never even heard of that. At an OBGYN office for about 12 years now. I didn't pick it. It picked me. A retired nurse. I deemed me as a good candidate. This is like other jobs that were just left in the comments that I thought we could highlight. I like it very much. It's a slower paced job. I'm going to have to look up what that is. Urodynamicist. Yes. Investigate. I sit with my patients for about an hour while I do the test, and I love working with. And for the women, it's repetitive, and I get the same intimate parts and stories from women, but I still love it. As someone else who likes the repetition, I'm here for it because you kind of like find your groove, and it's great, and I kind of like it. So that's another one we can look into. But yeah, anything else you guys want to add?
I thought that was great.
No.
Yeah.
Yeah.
I think healthcare is the best thing. I love being in healthcare. So
if you're going to work every day, if you're going to get out of your bed where it's warm and comfortable and put on clothes and leave the house, why not have it benefit other people? I mean, you can make money anywhere. And unless you want to make just tons of money, which you'll never make in nursing, but if you want to make an honest living, why not work hard and spend a day helping other people to make your living?
For sure.
I'm with Scott. I sleep in my bed very peacefully at night, knowing that I didn't swindle anybody. I didn't bamboozle anybody. Right. I saved lives. People are alive today. And I say this with all humility. Scott can say the same thing. People are alive on this planet today because of what I did or did not do in that moment. It's a heavy burden to bear. And it comes from a place of humility to say that, but it's true. People are alive today because of what I did or did not do in a single moment. So
you never know who you're going to influence and how. Something that you say. I don't know if I think about it in those terms, like I've saved lives and they would be dead, but for me or for us, But I do think from time to time I have a little pearl of wisdom that somebody who's going to think about, and later on they're going to go, that guy in the ER once told me that, and maybe.
Yeah. I bet I think it'll happen because I think we all the time you hear about people and you're like, oh yeah, I heard like from this one person that one time, you know what I mean? Like in healthcare, that one touch point. And then all the time in primary care, they're like, this one person one time told me. I'm like, how do you remember that? But I'm
I'll
glad
never
it worked.
forget that one nurse who told me.
Exactly. You're like,
so also,
what?
hey, nurses, be careful what you say. People are listening.
Absolutely.
A lot of, it's kind of like being a parent where you're like, this is
Mhm.
either you're going to go to a lot of therapy maybe about this one day, or it'll be that moment you look back and you're like, wow, they're the best. One of those moments.
Yep.
Yikes. It's no pressure at all. Everything's fine. Glissando girl says, I'm a tech in a retail clinic. I loved outpatient experiences too. Yes. If we have anyone that does outpatient stuff, do let us know. I'll try to give more warning next time. I've been a mess this week. Re-entering society after 2 weeks off was a lot. It was just a lot.
Nora gets my my quote. That's from a song from Into the Woods. Careful the things you say, children will listen. In this case,
I know that. Yes.
From Into the Woods. Yes.
There we go.
Nora
There we go. Wow,
girl.
that's been a minute. Yeah, Into the Woods. Nerlia says, I'm gay.
Yeah, Broadway queens. Yeah.
Oh my God.
Of course I do.
Love Nora. We love Nora.
Oh yeah, I have stories, but they're probably inappropriate. Related
That's
to
a whole other show.
Yes, it's not Tuesday. All right, friends.
Oh yeah.
I'm gonna go pack up a ton of sandwiches as quickly as I can because we're going. I probably shouldn't say where I'm going on the internet. We're going somewhere and the food's really expensive. So I'm cheap and I'm making everyone eat peanut butter and jelly on my husband's birthday. I'm like, here you go. Happy birthday. Have a
Tell
sandwich.
Joe happy birthday from us.
I will.
Yeah, I knew I liked him. He's a fellow Capricorn. My birthday's next week.
Well, there you go.
Happy
Are you doing
birthday,
anything
Scott.
for your birthday?
It's actually the night of the meeting for the California Association of Nurse Practitioners, the local chapter. They have monthly meetings, and usually I have them at a steakhouse. So I'm having a steak dinner, and I'm listening to some drug rep give a presentation, and that sounds good to me.
You know you're a nerd when.
Yeah.
It actually sounds good to me too. I'm like, wow, this is fancier than I'd be able to buy. So that's great. Thanks.
You get a steak dinner for $10. You can't beat it. So.
No, you really can't. You can get some really good food with some of that kind of stuff.
Drug
Yeah,
reps,
because
man.
the drug
like,
rep.
you want to
the
talk
drug
to
rep
me about
pick it
that medicine? I feel skeezy about it, but yes, you can buy me dinner at that.
This is we're hearing another part 2 of X-linked congenital hypophosphatemia, which I've never heard of.
Favorite topic.
Yeah, whatever. I'm like, that's fine. As long as they keep bringing the food, I'm good.
Just keep. And wine, keep. You bring it.
Yeah.
I'll just get more and more enthusiastic as the night goes on. I'm like, yes. I'm passionate about that lab value. Thank you for addressing it. I always wanted to know. All right, friends. Well, thank you for being here. And yeah, friends, thanks for being here. Let me know if you wanted a round 2 on all of these and some different specialties so that I can maybe go try to scout some people on the internet of what you would like to see. And yeah, remember that you are not alone. You are more than enough just as you are, whatever nursing specialty or non-nursing specialty, whatever it is you pick, and you can do the hard things. Bye, friends. Whoop.